closely, it's very important that you realize the All-on-4 is simply a concept. It is not a product. You can't go and buy an All-on-4. But it is something that today is in the vernacular. It is known to the public. It is something patients will come in and ask you about. They do to me. It's something that now the general public has an idea about, and how the treatment may be performed is unfortunately sometimes based on the number 4, which I would say unfortunately is misnomered. It has nothing to do, the All-on-4 concept has nothing to do with the number 4. And I hope by the end of the morning that I'll be able to pass along my rationale for saying that. This is the basis I have for actually being able to present some patients that may be a little bit more complex, maybe a little more complicated than those which you've perhaps considered for a full arch restoration in the past. Over the last 6 years, I was able to treat a lot of people. The practice I was in operated on 2 to 3 full arches per day and utilized this All-on-4 technology for immediate load in most of those patients. The minimum 4 months follow-up and the 100% graftless approach was part of the business model, along with immediate load. And it gave me an opportunity to look at not only how well this works and how life-changing this concept may be for many patients, but also an ability to collect complications. And that was the first thing I did whenever I saw a patient who was either more difficult than we'd seen before or who was experiencing complications with the treatment we provided. I had my camera out, and I was passionate about documenting complications, and I hope to be able to pass some of those along to you today. Let's start with one of the applications that really goes back a number of years, and that is the amount of bone which is available for implants to be placed in. We used to base everything that we did diagnostically on a panoramic film. We used to be hopeful that what we saw on this 2-dimensional X-ray would correlate to what we see in the mouth when we do our surgical procedures. Today we have a much better opportunity to actually treatment plan these patients, which is why I'll make the point early and make the point late that the cone beam CT, cone beam or CAT scan, whichever you wish to call it, the one that is now so much more available than it was 10 years ago in most offices, is the best diagnostic tool we have ever had in implant dentistry. It is probably the most important diagnostic tool I have when it comes to actually being able to diagnose and plan patients for what they may actually need, because there's so much information contained in these films. And it is also the best patient education tool. The solid model that you see right here that is on most software programs that are associated with the cone beam is very, very diagnostic and very helpful to try to explain to patients exactly what they have and what we have to deal with. As you can see with this particular patient, although everything looked pretty good on the panoramic film, there are areas where the bone volume is poor, where we have knife-edged alveolar processes, where we have very thin and almost absent triangular apical areas of bone. And what I look for in patients at the diagnostic phase is how much bone might be available here in the basal area. I'm not so concerned with this area, but here in the basal area. And I'm looking for apical triangles of bone into which we can place implants. And of course, by angulating, as you'll see, we can place these implants more effectively than we have been able to in the past. We can also angle our implants or place our implants in the area of the palatal ridge crest. You'll see that there's probably going to be threads exposed in some of these patients. But by angling and going palatal to the ridge crest, we engage more bone, and by angling the implants, we engage with longer implants more of the better bone that's available in this individual. By placing these 4 implants, we also create an enhanced anterior-posterior spread, which is one of the trademarks, one of the landmarks of the All-on-4 technique. In the days past, in years past, using vertical implants only, we were necessarily limiting the amount of spread that we had between implants. By doing that, we were then limiting the amount of cantilever force we could put on that particular restoration. By enhancing this spread, we can now sometimes come out in the area between the first molar and the second premolar, which minimizes the cantilever and vastly enhances your end result.